TDM. Go back to the 12. So go back to the 12.
Okay, we can go ahead.
Okay. So above 25 kgs, then we introduce TAF plus DTG as first line. Then second line will be AZT3TC Lopinava, not DTG. Next slide. So since I've introduced Tenofovir Alafenamide, TAF is an oral prodrug of Tenofovir. I'm sure you saw that from the polling question. It's approved for children for treatment of HIV in individuals weighing 25 kgs and above. Just a caveat there that giving TAF with rifamycin, example of rifamycin, is not recommended. Next slide. So some of the side effects of the TAF are nausea, diarrhea, headache. Then we have less common, but they can be severe lactic acidosis, severe hepatomegaly with fat changes, including fetal cases have been documented. Next slide. Okay. How is it eliminated from the body or metabolism? It's excreted by the kidney. So it's worked on by a system, we call them the adenosine triphosphates, dependent transport P-glycoproteins, and some people breast cancer resistance proteins. So that the ones which metabolize the TAF. Okay. So another caveat in terms of using TAF, if you are using TAF containing for co-formulations, we don't use it in patients whose creatinine clearance is less than 30 mils per minute, obviously because it's excreted by the kidney. Okay, so in terms of treatment, so that was Tenofovir, but it comes to HIV and TB co-infection. The treatment of TB in HIV individuals can use the following drugs, which are there listed: Abacavir, Lamivudine, and Dolutegravir. In this case, Dolutegravir will be given twice a day, so to 50 milligrams twice a day. Okay, the other combination you can use is Lamivudine, Lamivudine, and Dolutegravir or Dolutegravir. This is acceptable. Then there's also Abacavir, Lamivudine, and Dolutegravir. In this case, Dolutegravir dose should be doubled. Then Abacavir, Lamivudine, Lopinava, Ritonavir, where we super boost the Ritonavir. So when we say super boost, we mean that the dose of Lopinavir should be the same as the dose of Ritonavir. I'll just give you an example of what is currently available. Our formulations have Lopinavir 200 and the Ritonavir 50. So it means that if we say super boost, the dose of the Ritonavir, which is 50, has to be increased to 200. So it becomes 1-to-1. Then we also have another formulation of, it contains Lopinavir 100 and Ritonavir 25. So when you say super boost, it means that the dose of Ritonavir has to be increased to 100. So it will be 100. But unfortunately, this is a little bit of a challenge now because of the Ritonavir availability is still a challenge, especially for those of us who are in pediatrics. But our colleagues from the adult side, they have it. They have a 100 milligram tablet of Ritonavir. But so that's a bit of a challenge to us. Other combinations which I haven't included here because the talk was much more on DTG, Abacavir, Lamivudine, and Zidovudine when you have patients who have HIV and TB co-infection. We call it triple NOC. We still use that. The only challenge we have with that formulation is that the standalone drugs which are suitable for children are not available. The AZT3TC we have is the AZT60, and then the 3TC is 30, so 60-30. So to find standalone ABC, which is going to suit with the AZT3TC, is a challenge because the kind of formulation we have is a 300 milligram tablet of alacapa. So that one is still giving us a lot of issues. And then the other one we use is either ABC3TC efavirenz or AZT3TC efavirenz. Now, going on to the 2020 and I think onwards, efavirenz, I don't want to put it, all the NNRTs have been phased out in children. So we don't going to have formulations for younger ones because of increased resistance to NNRTs. The only one that you're going to see as being used is NEPAP in the first weeks of life. After that, we go to Lopinava. And then the TTG once you reach 20 kg and above. Next slide. Okay, so this is the dosage chart that has been introduced in the 2020 consolidated guidelines. So this one contains, it's just exactly the same as your dosage charts that we had before, but the difference with this one is that it shows you exactly what regimen should be used. So here we are showing the weight band. That's the first column. The next one is the strength of the drug, and then what regimen to give. So we've tried to simplify this so that people, when they look at the weight band, they know what drugs to give and how much to give. So for example, I'll start from the 3 to 5.9 kgs. This is exactly what is on your dosage chart if you can check it after this session. So the strength of the tablet here, or our regimen, let me put it this way. From the weight of that weight band, we go to our regimen which are recommended, which is ABC3TC and Lopinava. Okay, so in this case, we are saying if the kind of formulations you have is ABC3TC 60-30, Lopinava syrup, which is 80-20 milligrams per ml, when you're going to give this patient this prescription, your prescription will read as ABC3TC, 1 tablet twice a day, or BD, plus Lopinava, Ritonava, 1 ml BD. So the moment you look at this dosage chart, then you know, if you know what regimens to give, to tell you exactly how much to give. Because I've had issues of people not knowing exactly what regimens to give and then how much to give. This has led to poor viral suppression in our children. So it goes all the way up to 19.9 kgs, the ABC3TC Lopinava. Once you reach 20 kgs, then we introduce the Dolutegravir, which is the drug of discussion today. So, like I mentioned earlier, in this case, we are going to give abacavir, lamivudine, and Dolutegravir. The usual way we've been doing it, for example, for this patient weighing 20 to 24.9 would be abacavir, which is 300 milligram tablet, 3TC 150 milligram tablet, and DTG 50 milligram tablet. It will be, the usual way we have been doing it is abacavir in this case will be given 300 milligrams in the morning and 150 in the evening. So there we have put abacavir, the 300 and the 150 is 1.5 tablets. So that one I've given it as 1.5 tablets in the morning. I mean 1.5 tablet once. Same as the 3TC also be given the same as, ordinarily I would have been saying 150 in the morning, 75 in the evening. So the two put together will be 1.5 tablets. So here we're trying to leverage on the use of DTG, which is once a day. So our prescription will be ABC 1.5 tablet, 3TC 1.5 tablets, plus DTG 1 tablet. That's once a day. This we have seen that it works very well because here at PCOE, we've been using a once a day regimen for our children who are on efavirenz. And this has done very well because, you know, children need to play and all those challenges. So when you give it once a day, it has proved to be a good kind of approach to simplifying their regimen. Then when you reach 25 kgs, you go to TAF, which is put there. You can see this Tenofovir Alafenamide. FTC is emtricitabine, plus Dolutegravir. This is a fixed dose combination. It's one tablet. So you give it one tablet once a day. In above 30, obviously, you can use the famous TLD. Okay, next slide. So the difference with this dosage chart is that why I've put this one is that there's another one.
Second. Go back to it again.
Yes, yeah, it's okay. So that's it. So the dose of ABC3TC, which we'll be using onwards, I'm sure some facilities already have this. We have ABC3TC, which is 120/60. The previous one I showed was 60/30. But I know that 60/30, we are trying to move away from it because you just go to probably to 10 kg, the number of tablets increase. But this one, it reduces on pill burden, and this is a formulation which will be available in most of your facilities. So when you have the formulation, which is ABC3TC 120/60, how much to give in the terms of first line of ABC3TC half tablet plus Lopinava 1 ml. So it goes all the way up to 19.9 kgs, showing how much you are supposed to give. Next slide. Okay, so this one is similar to what I've explained, except that here we're talking about Zidovudin and Lamivudine, which is 260/30. This one will remain the same. And then this is the second line combination that we have. So AZT3TC plus Dolutegravir, then shows you how much to give. So this is the kind of dosage charts that we have introduced to try to make it simpler for people out there. Next slide. Okay, that's the end of the
all right.
question.
So thank you very much, Dr. Mwiya. I should apologize that we had a break in sound transmission from the hub, and definitely we failed to communicate. So if there are any clarifications during that period, you are welcome to do so. But before we actually go into the questions or clarifications, we'd like to once again go through the 4 questions which we had. So the first 4 question goes like, according to the 2020 Zambian Consolidated Guidelines and prevention of HIV infection, all of the following combination can be used in the treatment of HIV and TB co-infection, except according to the 2020 Zambia Consolidated Guidelines for treatment and prevention of HIV infection, all of the following combination can be used in the treatment of HIV and TB co-infection, except A, ABC3TC and DTG, B, AZT3TC and DTG, C, ABC3TC and Dolutegravir, D, TAF, FTC and DTG, then E, ABC3TC and Lopinava. So we ask that you give it a try. Sorry, I note that we're having a challenge in loading the poll, so just bear with us. We are trying to load the poll question so that you can give it a try. Imakando, are you hosting as well? If you can do it from your end. Okay, so there you have it. Let's give it a go. So okay, I think we seem to be having a technical hiccup with the pause, so I will definitely come back to them later. So I will ask the network to get any clarifications that they'll need. So please, if you have got any questions, feel free to ask now. Kindly remove the presentation. So we'll definitely come back to the poll questions later, but at this point, I'll ask if there are any clarifications to what has been presented so far. There was a clarification, I think a question from Mazabuka, if I'm not mistaken. Dr. Mwiya, they asked, that is Macha, sorry, they asked that if you use AZT3TC and DTG in the second line, are you supposed to give DTG as OD or BD?
Okay, so you use you give it once a day if the Dolutegravir was not used in the first line. So you give it once a day.
Okay, I hope that is answered and the clarification is given to Macha Mission. Is there anyone in the network who would like to ask for a clarification before we go to the case presentation for the day? Well, okay. Choma General, please go ahead. Choma, would you like to give it a go?
Yes, good afternoon, Dr. Mpeta.
Good afternoon.
And the team there. Yeah. Thank you so much, Dr. Mwiya, for the good presentation. We just want to find out with my colleagues here why TAF cannot be co-administered with the rifampicin. You just mentioned the slides, but then you didn't go into details. We wanted you to explain why TAF cannot be co-administered with rifampicin.
Okay. So
thank you.
All right, thank you very much. And Dr. Mwiya, maybe you can combine, apart from why TAF is not used with rifampicin, there's also a concern from Dr. Kavala saying TAF, FTC, and DTG are available. Dosing is different from what has been presented. Do we have the 200 milligrams FTC? So it's asking that what has been presented and what they have in the facilities are different. I don't know if you have a comment on that. So maybe the two can be addressed now.
Okay. Okay, so the first one, reason why we don't give rifampicin with TAF is that rifampicin activates the enzymes which metabolize the TAF such that the levels of TAF, plasma levels will be reduced. So you won't reach the therapeutic required amount of the drug in plasma for it to have an activity or in terms to have it have suppression of the virus as it is required. So that's the reason, just that the amount which plasma levels will be reduced. Then on the dose of FTC, we have TAF 25, then 200 of FTC.
Yes, so the FTC is not TAF.
No, oh, FTC, okay. I see
FTC
that.
we have 200.
Okay. No. So I think the confusion is this. Tenofovir, what we have is 3 drugs in one, which is TAF, is 25 milligrams?
Yes.
So 25 milligrams of Tenofovir Alafenamide, then FTC, which is the Tristabine, is 200 milligrams, and then the Dolutegravir is 50 milligrams. That's what we have. So what I'm saying by one tablet, that's exactly what I'm presenting is what we have. So these are tailored to what we have as stocks in our facilities, or what is recommended for our country. Like I've said, there are so many other combinations that TEF can go with. But for us, we have this particular one, which is just the TAF 25, then 200 Tristabine, and 50 milligrams of Dolutegravir.
Okay, so thank you very much. I've seen that Mazabuka, they have a hand raised up. Please, Mazabuka, go ahead. And then Dr. Kabala, we might ask you to type the question again, and then we'll give guidance, if that's okay with you. So Mazabuka, and as Mazabuka is asking, would like to ask Gladys Mabuku from
Hello, can you get us?
Yes, we can. Please go ahead.
Thank you. My clarification is on Lopinavir for children, those with TB co-infection. You said that because of the formulations, we can't boost Lopinavir. So I wanted the clarification on the recommendation.
Okay. So at the moment, we still have a Favires in the 200 milligram in the facilities. So we can use, depending on whether they are on, especially if they are on ABC3TC. So we are going to use, if they are on Lopinavir, better we go to a Favires. Okay, if they are on Dolutegravir, we continue Dolutegravir. If they are on Dolutegravir, we continue Dolutegravir. The other one which is supposed to be used is Abacavir, Lamivudine, and Zidovudine. Unfortunately, this is why I said we have a challenge with formulations. So the answer here would be, you will give Zidovudine, Lamivudine, DTG, or Zidovudine, Lamivudine, Dolutegravir, Abacavir, Lamivudine, Dolutegravir, or Abacavir, Lamivudine, Dolutegravir. Then you can use the Favires when it's still available in the facilities. I'm sure that way forward, you may not find the right formulations. So we'll stick to Dolutegravir or Dolutegravir. Unless, I know people will think of double dosing. This has been shown that it's not effective. Still, you find the doses of Lopinavir will be reduced, not reaching the therapeutic levels.
Okay, so thank you very much. If there are more clarifications, definitely we'll give a bit of time afterwards. But now I will ask if Yeta could go ahead and present. So if we can share the slides from here, Mr. Chatonda, and Dr. Chipasha and Gladys, please be ready to share or to start your presentation. The case. Okay, so please, Gladys, take over. Yeta. Yeta, please go ahead. You have been unmuted. Gladys?
Yes, I'm Gladys Mabuku, ART provider, Katima Sesheke District.
Please go ahead.
Presenting on a case of a female 13 years diagnosed with HIV in August 2012. Initiated on ABC, AZT, and NVP at Katima Health Center in later 2018. Presented to Katima with a cough, chest pains for 1 week, abnormal X-ray, and chronic malnutrition on the 14th of January 2020. Started on ATT and switched to AZT 3TC and DTG, which is BD. Mother was on ART, defaulted, and died in 2017. Father deserted the family before the child was even born. She's currently living with the aunt, who is a peasant farmer, and with the inadequate income. She stopped school last year due to persistent body weakness over a year. On examination, physical examination, vital signs on the 14th of January, temperature was 36.4, weight 22 kgs, height 1.35 meters, BMI 12, below the 50th percentile, and age, and for age and sex and height, underweight. Weight on the 10th of February 2020 was 23 kgs, BMI 12.6. Attempts at obtaining nutritional support is fertile. General examination, she looks small for age, silky, scanty, and discolored scalp hair, wasted, Turner stage 1, no lymphadenopathy. RIS, it was clear. CVS, tachycardia, PA, flat, soft, and non-tender. Clinical timeline and labs. The child was tested on the 18th of August 2012 and initiated on the same day. She was put on ABC, AZT, and NVP. Then on the 7th of November 2018, the child was switched on TLE, which is Avonza. Then on the 14th of January 2020, the child was switched on AZT, 3TC, and DTG. The lab results. HIV RDT was done on the 18th of August 2012, which was positive and commenced on ART. Viral load was done on the 29th of August 2019, which was 16,063 copies. It was repeated. The results were 2,180, and the child was enrolled on enhanced counseling. 3 sessions were done by the lay counselors. By then, there was no ART provider. Conducted with the caregiver and the child. Focus was on the dosing, and no doses missed. Keeps appointments. Then on the 10th of February 2020, viral load was collected, pending results. On the 10th of February 2020, CD4 was collected. The result came on the 13th of February 2020, which was 372 cells. HB, as on the 10th of February, results came on the 13th, which was 5.6 grams per deciliter. Chest X-ray was done on the 17th of January 2020, which had bilateral hair and lymphadenopathy, and she was commenced on 4F disease. Then gene expert, which was done on the 14th of January 2020, which came out negative. Creatinine was done on 10th February 2020. Results were ready by 13th of January 2020, which was 61. ALT done on the 10th of February 2020. Results were ready by 13th of January 2020, which was 56. Our questions are, in view of the exposure to ABC, AZT, NVP, in the current second line regimen appropriate, which is AZT, 3TC plus DTG? Is it appropriate for the child? The second one is, how can we improve pediatrics in enhanced adherence counseling? The child has documented 3 EAC sessions by the lay counselor. Thank you.
Thank you very much, Gladys, for the case and team. Before I ask the network to actually get clarifications, I would like to ensure that this is made clear. This child, the initial regimen was ABC, AZT, and NVP. Is that correct?
Yes.
Gladys?
Yes, that's what is on the file.
Sorry?
That's what is showing on the file.
On the file, okay.
Of the patient.
Consistently written like that, because I'm just wondering which, where the 3TC had gone, which is almost very difficult to find ABC or AZT without 3TC. Anyway, we'll take it that probably that's what the child got. So I will actually allow only 3 clarifications before we go into breakaway sessions to discuss the case. We are running a bit out of time, so please, if you could raise your hand if you need to ask for a clarification through the platform. And we'll definitely ask Sumbwanyambe to please kindly stop moving the camera as it is disturbing other participants. Thank you.
Dr. Mpeta.
All right. Yes, I've seen 2 participants. Shepherds. Please go ahead.
Dr. Mpeta, good afternoon.
Good afternoon.
I think the presenter didn't actually clarify on the initial regimen whether it was ABC, AZT, 3TC, or the 3TC had whether it's a typo error or something, because the presenter just says what is actually on the file.
Okay, so yeah, we note that, and I think we'll give them time to go through the file and to actually see what was discussed, and then probably they'll get back.
No, I think this patient was on, from the history we got coming out from Sesheke, is that this patient was initiated on AZT, ABC, nevirapine in Caprivi, in Katima, which is in Namibia. So they have no record. They only have something documented coming from Katima, which is in Namibia. So it's like that's what the patient was put on.
Yeah. So we'll take it that that's what the Namibians had started the patient on. Please, Mazapuka General, go ahead.
Hello?
Please go ahead.
Okay. My question is, were any investigations done on this patient prior to the presentation of TB? Because looking at the history of this child being unwell for over a year and dropping out of school before the commencement of ATT. And then my second question is, was it right to start this patient on AZT, looking at the level of the HB?
Okay, so your second question is what we'll be discussing in the breakaway sessions, but your first question, I'll ask Gladys to clarify. The last clarification is coming from, I don't know which one is CGH. Is it Chomageno or CGH? You have raised your hand.
Yes, please.
Which place is that? Those are just initials.
Isali General Hospital.
Which one?
Isali General Hospital.
Isali, thank you very much. Please, you should put the full name. Go ahead.
Yes, please. I was looking at the the date of the viral load, the date at which the test was done on the child, when the child was positive, and then trying to look at the time when the viral load was done.
Okay,
It's like 1 year passed. I wanted to understand what happened here. Is it because of the reason she said that there were no ART providers at the facility?
Okay, so thank you very much. Gladys,
Dr. Mpeta, just two important questions. Sorry, Dr. Ziambo here.
Yes, Doc.
Yeah, so just two important questions. Do we have any chance we might have the weight before they move to TLE? When the patient was on TLE, moving to the new treatment, SZT? And then is there any other adult within the family? Those two questions.
Okay, so thank you very much. Gladys, I'm sure you got those, especially the questions from Dr. Ziambo asking if there are any adults in the family, and then the other one, the weight at the time the patient was switched to TLE. And then the other question, I think, is other investigations that were done in this patient apart from the viral load. So you can go ahead and answer those.
Okay. I'm clarifying on the regimen. What is there on the file? It is saying, it is showing that the child was put on LVT and ABC, NVP. That was the initial treatment which was put on. And it's Katimamulilo, Zambia, which is in Sesheke district, not Katimamulilo, Namibia. Then the child was put on Avonza while the weight was 20 kgs. That is according to the file. Are there any other questions that I've left?
Okay. Yeah, I think the question was about any other investigations done. I can see that there's hemoglobin, creatinine, and ALT. And Chinsali, you wanted certain specific investigations. Is it Chinsali or Shepard who asked about investigations?
Okay, I think I can explain. I can try to explain what happened. This is a child we had to follow in the community to obtain recollection of these labs, because the first time it was done on the 14th of January, we were unable to trace these results with the lab. So we had to follow her home and recollect the sample. So from the time that we've received these lab results, we have not yet been in touch with the child.
Okay.
Otherwise, the child conducts more investigations, yes.
Okay, thank you very much for that clarification. We'll now go into breakaway sessions, and we have approximately 10 minutes, 5 minutes on each questions, and we get back here and share what we have discussed. So IT, please, let's assign the breakaway sessions. Thank you.
There's this there's a client, a child, a 13-year-old who was
Let's discuss this.
so
One, this child, the TLE, this child was weighing 20 kgs.
20 kgs. Yeah.
And TLE was too much for this child. It was below 35 kg.
So like this child.
We don't even know the results for creatinine. Did they give? It was okay. Okay.
So one, they mismanaged this is that at first they started the child on ABC3TC. But according to the Zambian basic system, we never had ABC standard.
From Namibia.
No, at Mwiya Zambia. They clarified.
Katima is Namibia.
But let's take it started on the same
From Namibia.
From Namibia, okay. But she said Katima from
Namibia.
This secret.
There's Katima Mwiro, Tashika and Katima Mwiro.
It's Katima.
Hello, everyone. Yes, you heard at in Zambia.
Okay, and then the other thing we shouldn't forget.
Kapata Clinic. Are you the ones moderating this group?
To the rest of the network, I think we don't have a host for this breakaway session. I don't know who the host is.
I believe
Yeah, so how do we,
and I'll be joining shortly.
So how do we go about it since we don't have a host and the time is ticking?
Yeah, exactly.
Maybe
That's what
someone take it up. A good Samaritan take it up since the time is going.
Which time is it?
Okay. So like here we discussed that the child was mismanaged in the sense that he was started on the TOE, the time the
there is no control per se. I can just see that I'm muted, the other one is muted. What is happening? Who's controlling it?
Okay, hi. I'll unmute everyone to allow the discussions.
We are too quiet.
Network, is it possible that the technician who allocated us to this breakaway session, is it possible that he can connect us to another breakaway session room where it's like we are left alone in this session?
I'm not sure if you can hear me. The people that will be joining with Dr. Ziambo, they had a problem with connectivity. So if possible, I suggest that maybe you carry on with the deliberations. Maybe one of you can take up the co-hosting or the facilitation until when Dr. Ziambo comes online.
Okay.
I propose Livingstone can take it up. At least we have a good number of people there who can see. Livingstone. Livingstone, we request you to help us to moderate while Dr. Ziambo is joining in. Livingstone.
Good afternoon, everyone. Good afternoon.
We can get you loud and clear.
Oh, thank you very much. As we saw from the presentation, I think what are some of the issues which you would like to bring on board? Looking at the regimen the child was put on, the issue of the creatinine, the HB, and other things. Maybe we can take it from there. What I was saying, what do you say on this case?
Hello, good afternoon, Tim.
Oh,
sorry.
Good afternoon.
We got disconnected. We had a problem with internet. And so we are just trying to connect back in. So how far have we gone in discussing the case? Sirondo.
Starting to discuss the case, just we are trying to wait for you, Dr. Ziambo, so that you can take it up. I think since now you are there, you can take it up.
All right. Thank you very much. So I know we are remaining with very limited time. What have we discussed regarding the first question? In view of exposure to ABC, SZT, and NVP, is there a current second-line regimen appropriate? Any views from the network?
Dr. Ziambo.
Yes.
Yes, maybe the other clarification we need to find out was the child switched from TLE to DTP without viral suppression record.
So they based it on the viral load that was done on the 11th of November. It was still valid, and that was after 3 sessions of ESC. So that's when they switched to SZT, I think.
Yeah, the viral load which there is while on TLE, the viral load on AZT, 3TC, DTG, they collected the sample, they are still waiting for the result.
Yeah. So what are some of the issues? What are some of the issues we can see about management in this patient so far?
From the reason actually is that in the first place, the regimen we are giving ABC, AZT, and Parapine. Actually, it is near the national guideline. So we are wondering child actually from the theater, how the child was on that regimen.
From the media,
Yeah, so it will be difficult for us to answer that question since Yeta is not here. Yeah, so I would suggest we can just highlight some of the issues we think were not appropriate, and then we go on to thinking what is appropriate here.
So that's it, like the first line there, it was not appropriate. Then again, when they were changing to second line, we saw that the HB was 5.6. Again, at 5.6, changing to AZT, it was not appropriate. I think that's what as a team here we are saying. Thank you.
All right, thank you very much. Any other comments?
Just to add,
yes.
Yes, from Choma. Yes, just as our colleagues have said, I think that you can see that the child was on the ABC and nevirapine, meaning that the child AZT, ABC, and nevirapine, and then switching the child to AZT based, it was not a good idea because the child had already failed in this one. He was just given pure therapy, which was not enough to cause the viral separation. There was some sort of mismanagement.
All right, thank you very much for that observation. NVP, same with EFC. So we are expecting probably resistances to have been the same. Thank you for that. Any other comments?
This is CGS, Chisar General Hospital, Doc.
Yes, please go ahead.
I was trying to look at the AOT. They managed to do the AOT, then the AST is outside it. I couldn't see them there. Maybe I would love this also to be clarified if they would be able to do that. The
Okay,
AST.
So
we will not have that, they are not here.
But AST is more hepatic specific, so this should be fine. Then AST. ALT is more specific to liver toxicity.
Okay, so what would be recommended drug of choice that would be appropriate at this stage for this team? I don't know if we can ask our experts to come in and help us before. Any thoughts out there? Yes, Kapata.
Hello?
Yes.
Yeah, we think the best recommended regimen would be Truvada DTG, seeing that this patient has already tested AZT since they had initiated, since she started treatment, and we think seeing this the HB of 5.6, it wouldn't be appropriate to continue with AZT. That's why we thought of replacing AZT with the Truvada DTG.
But Truvada, she is already failing on TDF 3TC efavirenz, so meaning Truvada is out. But how much it has gone out, we will know only by doing a resistance testing and scoring. But blindly, Truvada won't work for this child because the principle is there should be 2 fully active drugs and the third one can be partially active. So in this case, the fully active drug will be DTG and a PI. In this setup, I think the PI available will be Lopinava. And mind you again, she is on TB drugs with the rifampicin-based regime. So as we said, the DTG has to be given BD, 50 milligram BD. Has to be super boosted. And then we add the third drug, 3TC, as the partially active drug. Of course, they did the viral load. We just have to wait for the viral load result. If it is well suppressed, this is the regime. If she is not well suppressed, we have to do a resistance and then see. Then, of course, we hope the DTG is still working, then the BD will continue. and lopinavir super boosted with the rifampicin and 3TC. But then again, if there is option to change it to rifabutin, then you can give all the drugs in the normal dose. So it really depends on the availability of drugs and the viral load result, which is going to be out, I think, very soon.
So network, have we had that advice that has been given and highlighted that the use of Truvada in this case, it's considered that probably this could be failing. And since it was started in 2018, and had been taking it until November 2019. And then we see that the viral load still remained unsuppressed. So then, so I think that's the guidance is that probably we would use the integrase inhibitor, the PI, and the nucleoside reverse transcriptase. So this one, that means we have DTG, a PI, which is lopinavir, and then we have 3TC. Of course, also we need to do a drug resistant test, in this case, after we see the viral load result that has come out. Any concerns, clarifications on that issue? Yes, please go ahead, Smart Care.
Yeah, I'm from Mwandi Mission Hospital.
Okay, welcome, Wendy.
Yes, yes. So the thing is, looking at all the drugs the child got, we are thinking maybe the child can benefit from genotyping as we are waiting for the child to finish the TB treatment.
Yeah, if the viral load is high, we have to do that.
Have you heard that, Mwandi? That genotyping will follow a high viral load. Not its own.
And then we don't have the genotyping for the integrase inhibitor up to now. So we know only the other drugs, the genotyping for the other drugs.
Okay, so before we move on to the next, we go back to the breakout session. How would we help improve the pediatric enhanced adherence counseling in this particular patient? We still feel that there could have been a role of ESC to improve this patient.
Yeah. Those things we say, like as in probably.
Yeah.
Toma here, we just want to suggest something.
Yes, go ahead.
Yes, the EAC has been done several times by a lay counselor. Now, the challenge, we were supposed to involve the health workers themselves, especially when it comes to enhanced adherence in counseling. We have the.
I don't know how 15, that was the 12, 13, 14, 15, 16.
So please mute your, oh yeah, we are going back now. We have got 20 seconds to go back. But I do take note of your comment, Choma, that probably we could have used the healthcare workers, only lay counselors were used in this case. Any other quick comments? So I think for now, we can revert back to our the main session. We'll see you as we get back to the main session. Thank you.
You're confusing me. Okay, so thank you very much. I know that the discussions must have been interesting. So we'll straight away go to AIDC and listen to what their contributions or recommendations were on the two questions. So AIDC, please go ahead. Are they back? AIDC?
So the discussion we had here was the appropriateness of the AZT3TCDTG, and suggestions were that we should actually do another viral load. The worry about the HB and monitoring the HB, because we know that AZT may cause anemia, or equally it could be due to the nutritional status. So monitoring HB and the viral load, and considering adding a boosted PI with the second dose of DT as well, if we have issues with the viral load being high at this point. The problem with this is, the problem at this stage is, even if the viral load is suppressed, we won't know whether it's suppressed because of DTG monotherapy, because we know integrase inhibitors are quite powerful drugs, or whether the AZT3TC is still working. So resistance testing is another issue, which we ideally should have done it before the switch, but we may want to do it with the repeat viral load as well. Other issues that we discussed were regarding drug absorption and malnutrition, and supporting the adherence through peer-to-peer support. We were able to clarify from Yeta Hospital, they were in our group, that the household is quite large. There are 2 aunts with their own children and husbands, and the family has only 1 meal a day. And they're really stretched with food, so they really needed some social intervention. And I think Yeta is trying to link them with social welfare for additional support. We couldn't clarify whether this child was disclosed to. So disclosure is another issue which would also hamper adherence. So at this point, it wasn't clear whether this child had been disclosed to. So those are some of the points that we discussed.
All right, thank you very much, AIDC. I'll now go to breakaway room 2. I think there was Dr. Ziambo there.
Thank you so much, Dr. Mpeta. We were with Dr. Thomas here as one of the experts. And similarly, we were able to observe with the groups that we met, with the network we were in, that the regimen at all times were actually inappropriate. The first regimen, even the switch to a second regimen was inappropriate. And so there was an issue, and this is something that also we need to address in terms of healthcare workers. Then we thought and recommended similarly that because of the way that the drugs were being given, we're not too sure they may have acquired resistance. And so we proposed to have an integrase, a PI, and one of the NUCs. And so meaning DTG, lopinavir, and 3TC. But in this case, because of the presence of TB drugs, we may have to do DTG, BD, and lopinavir boosted, and then 3TC. Then we also looked at ESC need. There's great need to have ESC. In this case, it will have to be done by a counselor, a healthcare worker, a counselor, not lay counselors that were being supported at the time. So this we need to use a counselor or a healthcare worker to support them. And then we also would like to emphasize that the current guidance, according to our guidelines, is that the moment you have failure, moving on to a second line, we need to do genotyping. And so at this stage, genotyping should have been done as soon as they noticed that this patient was failing. Yeah, that's all in brief.
Okay, thank you very much. So we too had a very interesting discussion. Of course, like everyone has noted, there was inappropriateness of switch. Number one is there was anemia, so making AZT an inappropriate switch. Secondly, we also had seen on the second switch, which was to TLE, The TDF there was contraindicated in that the weight of the child was below what is recommended. Then 3, we also noted that documentation is very important by health workers. As we can see, there's something documented which doesn't exist both in the Zambian guidelines, or if we were to go across the border, which is in the Namibian guidelines. So meaning there was the issue of documentation, which has really caused a lot of confusion in this case. The second one was on the issue of involving professional providers, that is ART providers, rather than just lay counselors, because we have noted that this counseling was only done by lay counselors on 3 occasions. So if we don't see any improvement, we need to bring in ART providers and counselors and see how we can enhance adherence. Even DOTS can actually be something that can be administered. We also recommended that malnutrition should be addressed in this patient, and genotype should be done before we can actually determine what sort of regimen this child needs to be on. I think this is all we had, and there was just the emphasis definitely on adherence and documentation, which should be done. Chipata Central, we've noted your concern, and I think it's something that we are going to discuss here. We note that there was a technical hiccup. They could not be joined to any breakaway room session, and that actually, they just didn't join, I've been told. So there was some problem there. Okay, so quickly we are going to go through the poll questions, and this time there will only be 30 seconds. So the first question is, according to the 2020 guidelines for treatment of HIV and prevention, the following combination can be used in the treatment of HIV-TB co-infection except. So please, let's go ahead. Quickly, we only have 30 seconds for this. Why is it this one not showing time? Okay, thank you very much. Dr. Mwiya, any comment on that? The majority, that is 89%, have gone for D, and then we've got 8% going for C and only 3% going for 1.
No, I think here we use democracy, which is the operation of the minority. So the correct answer is for sure D. I think we've said in our presentation that TAF cannot be used with rifamycins, which includes rifampicin. So that's the correct.
There was a question which actually asked about why is that so?
No, I did explain that it's activation of the enzymes that metabolize TAF.
Okay, thank you very much. So the second one is reading, all the following are side effects of Dolutegravir except. So again, we are looking for an exception here. Let's go ahead and quickly vote so that we can see what we can do about this question as well. Okay, so thank you very much. Again, we have got 83% going for E, and then D, 13%, and C rash. Any comments on that again?
Answer is E, because the D, suicidal thoughts, I think that we presented that is one of those side effects that can happen, and even the rash, they have hypersensitivity reactions.
Okay, so thank you very much. There we go. We know how we have voted. The last poll question is on the statement. Which of the following statement is correct? So 1, TAF is not an oral prodrug of tenofovir. B, TAF is not approved for the treatment of HIV in individuals weighing above 30 kilos. C, TAF can be co-administered with rifampicin with no consequence. D, TAF is excreted by the kidney. TAF can cause hypersensitivity reactions. So please, let's go and vote. So which statement is correct? Here we are looking for the correct statement. So thank you very much, Dr. Mwiya. Again, the majority, 71, have gone for D. Then we have got about 18 going for C, and E going for 11% going for E.
Oh, the answer is D. TAF is excreted by the kidneys.
So the answer is D, and then definitely the other two, which is C and D, are false. All right, so thank you very much. There we have it. And the last thing we are going to do is just an update on coronavirus so that we know where we are. So what has happened since last week? We know that the virus now has been renamed from what was being called as 2019 nCoV to COVID 2019. Over 70,000 cases have been recorded and over 1,500 deaths worldwide. The majority of these cases and deaths being in the epicenter in Wuhan city. 29 countries have been affected, 99% of course still in China. For the first time, we have recorded a case that has been imported from China onto the African continent, and which is Egypt. So we know that now we have got a case reported in Africa. In Zambia, there is testing that has been established in Lusaka, and definitely screening is occurring at all points of entry, and they have been effected at all points of entry, which is the borders, the airports, and all that. Then we have got an alert system that has led to investigations of some of these cases which have been alerted. All the tests that we have done so far have come out negative, so we can effectively say that in Zambia, we don't have any case of coronavirus or COVID-19 as of this morning. Then we have screened patients, all right, in the past 14 days, and what we are doing is we are asking if there is any history of travel to or any history of residence in China, and then any history of contact with a confirmed or a probable case of COVID-19 infection. And then we are also asking if somebody has worked or attended in a healthcare facility where patients with confirmed or probable COVID infected patients are being treated. So we are still asking that if you have got any questions or you have got any requests to make concerning the COVID-19 virus, please, or infection, please call the following numbers that are projected on the screen. Any last words, Dr. Mwiya, about what we have discussed today?
Okay, so I think
especially pediatrics in ART, and the request that it needs to be repeated. So people want, there's a request already.
I should repeat. Okay, I think for me, what has come out from particularly the case is that it now emphasizes the reason why we have to come up with those particular kind of dosage charts, which shows the weight and the regimen to be given and how much to be given. Because if you saw, this child was given TLE at a time when it should not have been given TLE. Okay, so in terms of managing this patient, apart from whatever has been said, I think I haven't got anything who says exactly what they should do practically on the ground. Because right now, even if we say super boosting, that's not possible. And what do they have on the, so they have DTG, they have 3TC, and then they have a backup. Anemia, I mean, AZT is out. And like Mr. Kampamba said, the mother defaulted, clearly meaning that probably this child was also not being given medication. So chances are that their backup are still working. So the best we can do probably at this particular circumstance is to give a backup Alamuvudine and DTG, and then we monitor. Because I also felt that maybe the switch at the time they did switch to AZT, 3TC, DTG, was a bit of in a hurry, because CD4, I mean, clearly viral load was coming down from 16,000 to 2,000 in 3 months. So the EAC, I think, somehow here worked. Involvement of healthcare workers, sometimes it's like when I want to say something, people will say because you're a new TH. Out there, people that do EAC or who do these things are lay people. So let's also be cognizant of the fact that sometimes we're not in an ideal situation. There may be lay counselors that may do the EAC, like she said here, the health workers were not available. They're only lay counselors, but it's not encouraged. But wherever there are health workers, like those trained health workers, they must take a lead. Because what we have seen in most of the facilities that ART, particularly in children, is just by the way. Somebody who has time can go there. So that should be discouraged. At almost all the time, can we put people that are trained? I'm not saying the counselors are not trained, but you as health workers, take a minimum of 3 years to train to understand these things. Now you want somebody who went for a shorter time to come and take a lead. Let's not do that, because we're not doing our children a service. Thank you very much. I hope we have answered or helped Sesheke to solve problems of their patient. But also, please make sure nutrition is taken. I don't know how, but because they're eating only 1 meal a day, so it's a very big challenge. You know, there are any social network settings that can help, but I'm not very sure. Thank you.
All right, so the last, Gladys and team, is there any last clarification you would like to get based on what has been shared as the recommendation? And of course, definitely to be followed up by written recommendation. Gladys? Is there any clarification based on what has been recommended by Dr. Mwiya and all the groups that are deliberated on your case?
No, it is clear now.
Okay, thank you very much. So we'll be sending through a written recommendation so that it will help you in following step by step exactly what needs to be done in this patient. So next week, we shall be discussing another exciting topic, and this one will be looking at the package of care for advanced HIV disease. And definitely this will be discussing about the CRAG, cotrimoxazole, and cervical cancer screening in advanced HIV. It will be presented by a very exciting presenter who happens to be myself. So please ensure that you are in attendance for next week. From all of us in the hub, it's bye-bye and see you next week for another exciting session of ECHO. Thank you.